Hello, this is a video lesson on headwork. I'm going to start with the lateral projections, starting with the skull, that the patient would be in an RAO, LAO, seated, upright, or recumbent position. The mid-sagittal plane is parallel to the image receptor, and the IOML is parallel to the image receptor. The interpupillary line is perpendicular to the image receptor. We want to suspend respiration. For the central ray with perpendicular should be perpendicular, entering 2 inches superior to the EAM. Collimation is 1 inch beyond the skin line of the skull, and we should see superimposed halves of the cranium with the details at the side adjacent to the image receptor. The sella turcica, anterior clinoid processes, dorsum celli, and posterior clinoid processes are well visualized. So there's different options for the lateral skull positions. The patient can be in a lateral supine lateral, they can be upright, they can be in a dorsal decubitus with a cross-table lateral, or they can be in an RAO or LAO position. For the evaluation criteria, we're going to see evidence of proper collimation. We want to see the entire cranium without rotation or tilt, where we can see superimposed orbital roofs and the greater wings of the sphenoid. The superimposed mastoid regions in the EAM. We should also see superimposed TMJs, and the sella turcica should always be in profile on a lateral projection of the head for headwork. On a lateral projection for facial bones, the patient is in the same position as it was for the skull, and the position of the part is the same as well. Respiration is the same. The difference is the central ray, and so it's going to be perpendicular, entering the lateral surface of the zygomatic bone, halfway between the outer canthus and the EAM. Collimation should be 6 by 10. We're going to get lateral projections at the bones of the face with right and left sides superimposed. So for this image, we're looking at all the facial bones in their entirety with the zygomatic bone in the center. There should be no rotation or tilt of the facial bones, demonstrated by almost perfectly superimposed mandibular rami, superimposed orbital roofs, and the sella turcica, as always, is in profile. For nasal bones, the positioning of the part and the patient is the same as again, and so is the respiration. This time we're going to center to a perpendicular to a midpoint 1 inch distal to the nasion, and the collimation is now a 3 by 3. We're going to see the structures shown as the nasal bone and the soft tissues of the nose closer to the image receptor, and both sides are examined for comparison. And so looking at the two images for this is we're going to be taking a look at the nasal bones, anterior nasal spine, and the frontonasal suture. There should be no rotation of the nasal bones in the soft tissue. For lateral projection of the orbits, again, the patient position and the positioning of the part should be the same, as well as the respiratory instructions for the other laterals, but the central ray this time is to the mid-orbits. The patient should look straight ahead for the exposure, and we should adjust to the orbital region for the collimation. We want to see a lateral projection of the orbit. So we should see the entire orbit with the superimposed orbital roofs. We want close beam collimation centered to the orbital region. For the lateral projection of the sinuses, the positioning is the same as it was for the patient and for the part, and respiration is the same. The central ray is now 1 inch posterior to the outer canthus. So our collimation is an 8 by 10. We should see AP and superior inferior dimensions of the paranasal sinuses, their relationship to the surrounding structures, and the thickness of the outer table of the frontal bone. For the evaluation criteria, we should see all 4 sinus groups. That's the one thing that's important with this, all 4 sinus groups, but the sphenoid sinus is demonstrated the best, and it is the most superior set of sinuses. There should be no rotation or tilt of the sinus anatomy. The sella turcica is always in profile. The superior orbital roofs, there should be superimposed mandibular rami. Now to move on to a different projection, we're looking at a PA projection of the skull. In this projection, the patient is prone or seated. They're centered with mid-sagittal plane with the midline to the image receptor. They're going to rest their forehead and the nose on the image receptor. We're going to flex the elbow and place the arms in a comfortable position. The mid-sagittal plane and the OML are perpendicular to the image receptor. The respiration is suspension, and we're going to center to perpendicular to exit the nasion. We're going to have collimation 1 inch beyond the skin line of the skull. The orbit should be filled by the petrous ridges and the ethmoid air cells. Cystic alley, frontal bone, and frontal sinuses are demonstrated. So in this projection, we can see that the orbits are filled by the petrous ridges, as can be seen. We're going to look at the equidistances between the lateral borders of the skull to the lateral borders of the orbits on both sides. We should see symmetric petrous ridges, and the mid-sagittal plane of the cranium is aligned with the long axis of the collimated field. The entire cranium perimeter should be showing 3 distinct tables of squamous bone. For the PA axial projection Colville method, the position of the patient and position of the part and the respiration is the same as it was for the PA projection. The difference is the central ray is going to exit the nasion at the angle of 15 degrees cauded. Our collimation should be 1 inch beyond the skin line of the skull, and we're going to have the petrous ridges projected into the lower 1/3 of the orbits. This also shows the anterior ethmoid air cells. This projection is used for various imaging of the various parts of the headwork, including the skull, facial bones, orbits, and even nasal bones and sinuses. So we're looking at the PA projection demonstrates the petrous ridges lying in the lower 1/3 of the orbit, and we want to see the entire cranium without rotation or tilt. Now, the question is, which one of these is the PA versus the PA axial? The PA is on the left because the petrous ridges fill the orbit. The PA axial is on the right because the petrous ridges are in the lower 1/3 of the orbit. And that's where we're seeing they're down here. Where on the PA projection, they fill the orbit. We can also do AP and AP axials instead if the patient's condition doesn't permit the PA projection. It's the same positioning as we did with the PA and PA axial. The AP axial is also called a reverse Caldwell for trauma situations. Instead of cauded angulation, we're going to use a cephalad angulation on the Caldwell method, and the beam will enter the nasion instead. The orbits will be magnified. So which one is the AP versus the PA projection? And that is the AP projection is going to be the one with the larger orbits. There's going to be more modification on the AP projection. The PA axial projection for the sinuses is going to be the same positioning as we have with the PA axial Caldwell, except that we need to use a horizontal beam. So we're going to make sure that we adjust the patient's head so the OML creates a 15-degree angulation with the image receptor. The nose is on the image receptor. So we're going to exit the nasion just as we would with the PA axial Caldwell, and we're going to visualize the frontal sinuses lying superior to the frontonasal suture, and the anterior ethmoid air cells are shown. The petrous ridges are lying in the inferior third of the orbit, and it shows the frontal sinuses and the anterior ethmoidal air cells. And so looking at the images, we're looking at the two major set of sinuses that are visualized, the frontal sinuses and the ethmoidal air cells, specifically the anterior ones. The apiaxial town method is used for only the skull. It's first the positioning that we're going to take a look at here. We're going to have the patient supine or seated with them upright, or we can have them, and we want to center the mid-sagittal plane to the midline of the image receptor. The mid-sagittal plane is perpendicular to the image receptor. We want to suspend respiration. For the central ray, it depends upon how much the patient can tuck their chin. But we want the central ray directed to the foramen magnum, and we want to use a 30-degree caudate angulation if we're using the OML perpendicular to the image receptor, and we use a 37-degree caudate angulation if we have the IOML perpendicular to the image receptor. The central ray should enter 2.5 inches above the glabella and passes through the level of the EAM. For collimation, we want to go 1 inch beyond the skin line of the skull, and the structure shown is that we see the petrous ridges, the posterior portion of the foramen magnum, the dorsum celli, and the posterior ciliary processes within the foramen magnum, the occipital bone, and the posterior portion of the parietal bone is visualized. So this is just showing that if we have a 30-degree caudate angulation, that would work along with having the OML perpendicular to the image receptor, or if the IOML is perpendicular to the image receptor, then we want to use a 37-degree caudate angulation. And then if we have a trauma AP axial Tau method, we'd increase the CR angulation to 40 to 60 degrees caudate. So for the Tau method, we want to see the entire cranium without tilt, and we want to see the dorsum celli and the posterior ciliary processes projected and visible within the foramen magnum. The SMV projection, which is called the Schuller method, is a position in which the patient is supine or seated upright. The IOML is parallel with the image receptor, just like it was with the lateral projection of the headwork. The mid-sagittal plane is perpendicular to the IR, and you want to extend the patient's neck to the greatest extent. You'll see in these projections and these pictures that the vertex of the skull is on the image receptor. You want to direct the central ray through the sella turcica perpendicular to the IOML. It enters the mid-sagittal plane of the throat to the angles of the mandible and passes through 0.3/4 of an inch anterior to the level of the EAM. Collimation is 1 inch beyond the shadow of the tip of the nose and 1 inch beyond the lateral borders. For structures shown, we're going to see symmetric images of the petrosa, mastoid processes, the foraminoval and spinosum, the carotid canals, the sphenoidal and ethmoidal sinuses, the mandible, the bony nasal septum, the dens of the axis, and the occipital bone. So looking at all the different structures that we can see here, there's quite a few. The IOML is parallel with the image receptor, and that's can be demonstrated by the mental protuberance superimposed over the anterior frontal bone. And the mandibular condyles are anterior to the petrosa. So there's the petrosa here, and the mandibular condyles are anterior to it. There's the condyles. For the SMV for sinuses, we want to use the same positioning, except the patient should be upright or seated. We're not going to have them supine. We still want the IOML parallel to the image receptor, and the mid-sagittal plane is centered to the IR. We want the rest of the head on the vertex, and the suspension for the breathing is the same. We want the horizontal being perpendicular to the IOML projected to the sella turcica, and we should be entering 3/4 cents anterior to the level of the EAM. The collimation should be an 8/10, and we should see the sphenoidal and the ethmoidal air cells. And so that's the key to this one, is that we have our sphenoidal and our ethmoidal air cells that are visualized. There's the ethmoidals and there's the sphenoidal. Again, the IOML is positioned parallel to the image receptor. It's demonstrated by the anterior frontal bone superimposed by the mental protuberance, and then we can also see that the condyles, mandibular condyles, are anterior to the petrous ridges, as we saw in the previous evaluation criteria of the SMV. The parietal acanthial projection Waters method. Your patient can be prone or seated upright. They can center the mid-sagittal plane to the midline of the image receptor. The mid-sagittal plane should be perpendicular to the IR. We want to rest the head on the tip of the extended chin. The OML forms a 37-degree angle with the plane of the image receptor, and that means that the MML is almost perpendicular to the IR. And that's shown in their image down here, that we've got a 37-degree angle that's formed between the OML and the plane of the image receptor, and the MML is nearly perpendicular with the image receptor. The nose should be about 3/4 of an inch away from the image receptor. We're going to suspend respiration and we're going to exit the acanthion. Our collimation's an 8 by 10, and we're going to visualize the orbits, the maxilla, and our zygomatic arches. So taking a look at this image, we're looking at the image of the entire orbits and facial bones. We have no rotation or tilt, which is demonstrated by the lateral borders of the skull and the orbits equal on both sides. The mid-sagittal plane of the head is aligned with the long axis of the collimated field. And the petrous ridges, this is very important, should be projected immediately below the maxillary sinuses. So the petrous ridges are below, here they are down here, petrous ridges below the maxillary sinuses, and that's why we can see the maxillary sinuses so well on this image. We should also see the dens should be found within the foramen magnum on this image. On the parietal canthial projection modified waters, we're looking at the patient being in the seated or prone position. The mid-sagittal plane is still perpendicular to the midplane of the image receptor, and we still have everything is the same about the positioning of the part, except that the OML forms a 55-degree angle with the plane of the image receptor instead of a 37. That means that the nose is only about a half an inch away from the image receptor this time. For respiration, it's on suspension, and we're going to have our beam perpendicular to exit the acanthion. The petrous ridges are projected immediately below the inferior border of the orbits midway through the maxillary sinuses. And this is great for MRI images and for blowout fractures of the orbits. So we're going to have the petrous ridges immediately below the inferior border of the orbits, midway through the maxillary sinuses. This is something that's very different, so it's not for maxillary sinuses and does not show them. The purpose is to look at blowout fractures of the orbits, and it's for, which would be at the lower border of the orbit, and it's also used for the for MRI, looking for foreign bodies for MRI exams. So here's the difference between the Waters method and the modified Waters. The Waters method on the left-hand side shows the 37-degree angle formed with the image receptor. The MML is nearly perpendicular to the image receptor, where the modified Waters called a shallow Waters, and it's where there's a 55-degree angulation now, and the nose is only half an inch off the image receptor. And here's the two images side by side. In the Waters method, you can see the dens inside in the foramen magnum. You can also see that the maxillary sinuses are completely clear, and that the petrous ridges are projected below the maxillary sinuses. In the modified Waters, the petrous ridges are in the maxillary sinuses. Canthioparietal projection reverse Waters method is another option you have for the Waters. And so this is patient is in a supine position because this is a position for patients who have been in a trauma. So they want to center the mid-sagittal plane of the body to the midline of the grid. The mid-sagittal plane is perpendicular to the IR, and we want to extend the neck so the OML forms a 37-degree angle with the plane of the image receptor. The MML is almost perpendicular with the image receptor. So we want to suspend respiration, and we want to enter the acanthion this time since the patient is supine. We want to have the collimation to be to an 8 by 10, and we want to see the superior facial bones. The image is similar to the Waters method, but is magnified. For the evaluation criteria, the image is going to be the same as it was for the Waters, except that the image will be magnified in comparison, but the petrous ridges are projected below the maxillary sinuses. image shown here is such a patient who has severe nasal trauma, nasal bone trauma, so that's why the image looks so different than what we saw previously. This concludes our lesson on the first part of Headwork. Have a great day.